supraannular position. The short film valves like sapien valve and my valve, they are the balloon expandable valves and short film valves, and they have leaflets at intraannular position. I will go in depth what is intraannular and supraannular in the next coming slides. And rapid deployment, so deployment, most of the balloon expanding valves have rapid deployments, one inflation, that's all. There is a deployment of the balloon expandable valves. Where had the self-expandable valves, it is slowly unsheathing the valve frame. It is called the slow deployment. So basically the difference between the balloon expandable valve and self-expandable valve. So the stall frame valve is a self-expandable valve. It is a nitinol-based frame, and then inside the leaflets will be there made up of a bovine pericardium, and we can see this is the red mark is the annulus level, and there will be a lot of cells, and this blue dot is the position of the leaflets, the transcatheteral leaflets. So we can see the distance between the annulus and the position of the leaflets. So it is the supraannular position of the leaflets. Why they have designed this supraannular leaflet position? Because the opening will be more at the supraannular position than at the annular position, so that we can get a better EOA, that is effective opening orifice. So we can get a better EOA, so there will be less patient-process mismatch and better hemodynamics in case of a self-expanding valve or supraannular valve. And outer there will be a skirt up to 2 diamonds. We call it as nodes. This is node 0, this is node 1, this is node 2, and this is node 3. So up to node 3, around 13-14 millimeters, depending upon the size of the evolute valve, there will be outer skirt which will prevent the paravalvular leakage from outside the cage of the valve. So these are called the commercial posts. 3 will be there, and these 3 should match the negative commissures whenever we are deploying the valve, so that we can avoid the coronary obstruction. So on the other hand, this is the balloon expandable valve. This is actually a Merrill valve, my valve, almost similar to the sapien valve by Edwards. So there will be a short frame valve. The leaflets will be at the level of the annular position. So theoretically, the effective orifice area is less when compared with that of the self-expandable valves. So there can be a patient-prosthetic mismatch that we are going to discuss in the next slides. So basically, these are the 2 types, self-expandable valve and a balloon expandable valve. So saying that in 90% of the cases, we can deploy any of this self-expandable valve or balloon expandable valve. But there are certain clinical subsets, certain anatomies, which will demand a specific valve. That is, in this particular case, a self-expandable valve is ideal. In this particular anatomy, a balloon expandable valve is ideal. So these are the particular subsets which I have chosen today for discussion. Bicuspid aortic valve, in which the cusps are 2 and there can be asymmetry because of the fugit raphe with a lot of calcium and dilated ascending aorta. Small annulus. A patient with small annulus, there will be a problem of patient-process mismatch. So we should be wise enough to choose a ideal valve in the small annulus patients. Again, maintaining the future coronary axis. And patient with low coronary heights, we have to choose the ideal valve so that because we can't afford a coronary obstruction on the table, which is a catastrophic. Similarly, the lifetime element of the patient, if a patient with a TAVI valve outlives the lifetime of a valve, then we have to plan the valve-in-valve procedures like TAVI and TAVI. Similarly, in a degenerated surgical valve, in a degenerated previously implanted surgical valve, we may have to plan a TAVI. So that is a separate subset, and we have to plan an ideal valve depending upon the size and position of the initial valve. Similarly, in patient with high pacemaker risk, we have to choose a different valves. Similarly, in patient with aortic regurgitation also, now we are doing the TAVIs. So what are the valves that are suited for the aortic regurgitation? Similarly, all TAVIs now we are doing transfemoral, but sometimes there will be a hostile femorals. We have to go from the other axis like a subclavian, axillary, or transaortic So then we have to choose the different valve frames and the catheters. So coming to the bicuspid valve first, we'll go one by one quickly. So coming to the bicuspid aortic valve. So bicuspid, well, my meaning there will be two curves. Sometimes it is if there are only two curves and there are no raphe, it is called type 0. If they are having a fused one raphe, then it is called type 1 bicuspid. More common is the fused raphe between the right and left, and then the right and non, and the least common is the left and non fusion of the cusp and raphe. So these are the type 1, which is most common. Type 2, if there are two raphe, it is called the type 2. So this is called Sevier's classification. And depending upon the type, there can be a specific challenges while doing the TAVR. So most of the time, all the tricuspid valves, so the root will be in a rectangular shape, meaning the annulus diameter and the diameter 4 or 6 centimeters above in the aortic root, it will be the same. But in some of the bicuspids, so it can be a taper type, meaning the annulus is larger, and above the annulus it is the smaller when coming towards the sinotubular junction. Then we have to size the valve above the annulus, not to the annulus. Generally, we will size the valve to the annulus. If it is flare or normal rectangle shape or tubular type, if you size to the annulus, it will be okay. But if it is taper type, we have to size to the supraannular sizing. So because of the anatomical complexity, because there will be a abnormal cusp fusion, asymmetry of the valve orifice, and heavily calcium and calcified raphe, the transcatheter heart valve deployment in bicuspid valve can be challenging. The problem is there are no randomized data trials for bicuspid valves in TAVI, because all the initial trials like these partner trials and core valve or evolute risk trials, the bicuspid valves has been excluded. So with the initial generation devices like the initial generation of the evolute valves and sapien valves, there is high incidence of paravalvular leak because the orifice is asymmetric. There will be a lot of calcium, improper valve expansion. So there is a lot of paravalvular leak in bicuspid valves. Similarly, there is a permanent pacemaker implantation rate will be high. Similarly, patient process mismatch is high. And if you oversize, there will be a risk of annular rupture. And if you undersize, there is a risk of valve migration needing the second valve. But with the significant improvements in the design and delivery system of the third generation valves, along with the widespread use of the CT itogram for aortic root sizing and annular sizing, it leads to a better procedural success in the TAVI for bicuspid aortic valves. So if you see, so these are the different parameters. If you choose a balloon expandable valve or self-expandable valve in bicuspid aortic valve, so the pre-dilatation. So for any TAVI procedure, there will be 3 steps like coronary, the pre-dilatation, deployment of the valve, and if required, post-dilatation like a coronary. So the requirement for pre-dilatation is more if you use a self-expandable valve in any of the series. This BEV is balloon expandable valve. This SEV is the self-expandable valves. Why? Because there is a lot of calcium, so we need a pre-dilatation. Similarly, in the coronary lesions, if the lesion has too much calcium and fibrosis, definitely we have to pre-dilate and prepare the lesion. Likewise, the pre-dilatation requirement is more in a self-expandable valve rather than a balloon expandable valve. And post-dilatation also, because of the high incidence of paravalvular leak in a self-expandable valve, the post-dilatation need also will be more if you choose a self-expandable valve. The risk of annular rupture is more as expected with the balloon expandable valve because it is a one-time inflation, there will be no control. So if you oversize the valve to the annulus, there will be a risk of the annular rupture if you choose a balloon expandable valve. But if you look at the gradient, as I told you before, the gradients and effective orifice area are better if you choose a self-expandable valve. But at the same time, the paravalvular leak will be more because of this self-expandable valves. the radial strength is less when compared with the balloon expandable valve initially. So there can be a leakage around the valve frame, so the paravalvular leak can be more. As expected, the pacemaker risk is more with the self-expandable valves because these are tall frame valves, and the tall frame valve, the self-expandable valve nitinol has a property of expanding even after the deployment, and this may impinge on the conducting system causing the pacemaker. So in short, for self-expandable valve, there will be require more pre-dilatation, post-dilatation, and high requirement of pacemaker. For balloon expandable valve, the risk of annular rupture is more, and we'll get better hemodynamics with the self-expandable valve, but at the cost of increased risk of paravalvular leak. So these are the different trials with the balloon expandable valve and bicuspid aortic valve, different registries. Among this, the Partner 3 trial recently completed the 5 years follow-up and it was published. And the device success rate is good even in bicuspid valves also. Now we have conquered the bicuspid also in TAVI era. And so the new pacemaker risk with the initial generations, the pacemaker risk was high, but as the valves evolve, the pacemaker risk is low. So these are the different trials with the bicuspid aortic valve and self-expandable valves. This evaluate low risk trial and evaluate X are the recently published and completed 5 years of follow-up. In this also, the device success rate is almost 90%. And has expected a little bit of increase in the paravalvular leak with the self-expandable valves. But overall, either self-expandable valve or balloon expandable valve, the bicuspid valves, the device success rate is good. And depending upon the other anatomical factors, we have to choose the valve. Sharing a case example here, we can see this is a 75 years male presented with syncope and class 2 dyspnea. If you see the echo, Doppler across the aortic valve, the mean gradient is 64 and peak gradient is 91. In view of the high surgical risk, TAVI was planned. So we can see the CT anatomy here. This is a bicuspid valve and there is a fugal cusp between the right and the left. So this is the right cusp, this is the left cusp, this is the non-coronary cusp. We can see the fugal cusp between the left and the right, and we can see the calcium also. And see, so this is the CT analysis the company people will give you for any patient if you are planning for the TAVI. So basically, it will give you the measurement of the annulus and the diameters of the sinuses of Valsalva and the heights of the coronaries from the annulus and the different diameters and perimeters of the annulus. So in our patient, the area is 449 millimeters square and the area derived diameter is 23.9. So in our patient, the annulus diameter is 23.9 and LVOT is 24.7. So I have chosen a valve of 24.5, approximately oversizing by the 5%. Generally, we will oversize between 10 to 15%. For a bicuspid aortic valve, we will oversize a little less. Why? Because there will be an asymmetric calcium and asymmetric fusion. So the risk of rupture will be more. So we'll choose a 5% oversize. So this is a 24.5. A balloon expandable valve was chosen in this case. So this is positioning the valve. This is the balloon expandable valve. Like our stent, we can see we have positioned across the annulus, 80% above the annulus and 20% below the annulus. And under rapid pacing, we can see a temporary pacing here. Keeping in the RV, we are pacing, decreasing the blood pressure and inflating the balloon just like our stent. And this is the post angiogram showing. So we have to check 3 things in the post angiogram: any aortic regurgitation and the patency of the coronaries and any rupture or anything is there. So with this, this is the pre-procedure hemodynamics. The yellow color is the LV pressure, red color is the aortic pressure. We can see there is a gradient peak to mean, peak to peak around 40 to 50. This is the post-procedure hemodynamics. Absolutely, there is no gradient. So, and this is the Doppler. Initially, we have seen mean gradient of around 64. Now it is the 2.5. So there is no gradient across the aortic valve. There is no paravalvular leak, no conduction abnormalities, and no root rupture. Initially, I told you the ideal characteristics of a valve. So we have issued almost everything by deploying a balloon expandable valve in this bicuspid valve. Similarly, I show you a second case. This is again a 74 years recurrent heart failure admissions. We can see severe aortic stenosis with P gradient of 140, mean gradient of 93, and EF of 40. Again, in view of 74 years, high surgical risk, we have chosen TAVI in this patient. We can see the bicuspid valve. So if you remember the Sievert's classification, here there are only two curves. So it is a, and there are no raphe. It is a severe bicuspid type 0. And the annulus diameter is here 25. And as I mentioned before, we have to measure the diameters above the annulus also for bicuspid valve patients. That is called intercommissural distance. It is 25.1. So almost similar to the annulus diameter. So it is a tubular type bicuspid valve. The coronary heights are good, 13.2 and 17.5. And we have to measure the femoral diameters also. Anything above 6 is good for a 16 French or 18 French delivery system catheter. And sciences of pulsal valve. Here there are only two measurements because of the type 0, severe type bicuspid valve. In this case, we have chosen a self-expandable valve. This is placing of a wire into the LV. For coronary lesions, we are wiring the lesion. Similarly, we have to place a stiff wire in the LV across the aortic valve. And because of the severe calcium on the bicuspid valve, this patient will have pre-dilated. This is pre-dilatation. And this is the positioning the valve across the aortic valve. This is a self-expandable valve like a Medtronic valve. So we have to position at least 3 to 5 millimeters below this pictet. Usually this pictal catheter will be in non-coronary sinus. We have to position at least 3 to 5 mm into the LV, and we have to start unsheathing under rapid pacing. So this is the self-expandable valve which we have deployed, and post-echo we see no paravalvular leak or no gradient. Coming to the small annulus. So small annulus, what is the definition of a small annulus? So small annulus was defined as anything less than 430 millimeter square of the annular diameter or 23 mm. So around 40% of the patient, especially in India and Asian subcontinent, they have small annulus. What is the problem with small annulus? There is a risk of patient process mismatch if we are not selecting the proper device. So we have data from two trials. One is a randomized trial called SMART trial, and one is a registry data called SMALL 2 registry. So if you see the comparison between supraannular or self-expandable valves or intraannular or balloon expandable valves, if you choose a self-expandable valve, the mean AV valve, aortic valve gradient or maximum aortic valve gradient or the indexed EOA, they are better with the supraannular valves or self-expandable valves. So the reason I told you, because of the position of the leaflets, we are getting the better hemodynamics. So this is data from a SMART trial. So most of the patients are females, around 4,000 odd patients. They have randomized between the self-expandable valve and a balloon expandable valve, that is between the evolute valve and the sapien valve. So what they have found out, the bioprosthetic valve dysfunction at the end of the 2 years, it is more with the balloon expandable valves. It is statistically significant. But the problem is this bioprosthetic valve function has not translated into the hard clinical endpoints like death, disabling stroke or heart failure hospitalization. So what we can conclude from this small trial, in a small annulus, if you choose a self-expandable valve, we can get a better hemodynamics, but the hard endpoints are not suggesting any valve. So we will get a better hemodynamics and higher effective orifice area if you choose a self-expandable valve in a small annulus. So for any degree of patient prosthetic mismatch, the self-expandable valve will do better than a balloon expandable valve in the small annulus. So what we can conclude that severe symptomatic aortic stenosis and small aortic valve undergoing TAVI, implantation of a self-expandable valve compared to balloon expandable valve are associated with similar clinical outcomes, but with the self-expandable valve, we will get better valvular hemodynamics and less bioprosthetic valve dysfunction. So I will show a small case example. This is a 73 years female diabetic hypertension presented with acute heart failure. We can see ECG normal and our echocardiogram was CEG was non-obstructive. Echo showing severe aortic stenosis. Again, in view of the IHTS score, the TAVI was planned. Here, annulus we can see the perimeter is 63.6 and area is 296 and area derived is 20.2. As per definition, any annulus size less than 23 is called the small annulus, and any area less than 430 was small annulus. So other parameters we have seen, this is a tricuspid valve. Beautifully we can see three curves, and these are the signs of valsalva diameter. So because it is a small annulus, so we have chosen a self-expandable valve. By Medtronic is an Evolute Pro Plus, the initial generation of the Evolute valve. Of course, the latest generation is called Evolute FX Plus, which is now available in India, based on the annulus diameter of 20.2 and annulus perimeter of 63.6. We have chosen a valve of 23 in this patient, which will roughly oversize around 14. For a self-expandable valve, up to 14 size oversize is the okay. So standard procedure of the TAVI figures I am showing repeatedly. So one pacemaker in the RV, one pigtail in the non-coronary cusp for the aortograms and crossing the valve, and a pre-dilatation with the 16 mm balloon. And these are the pre-procedural hemodynamics. The blue color is the ventricle, red color is the aorta. We can see the gradient around 50. And these are the standard steps for the Evolute self-expandable valve deployment. So this is tracking the valve over the stiff wire, and there are certain alignments, certain adjustments to get the coronary or commissural alignment. We can see a marker here that is called the hat marker. So that should be front. So we call it as center front in RAO view. In LAO, it should be on the outer curvature. This is just to get the commissural alignment. Although this is not important at this point of discussion. So this is releasing the valve, and this is after the release of the valve, the aortogram. There is no AR, the coronaries are flowing. We can see the coronaries which are flowing, and the gradient is 4. So initially what is there, the 60 gradient is now 4. So in this patient with a small annulus, by choosing the self-expandable valves, we have achieved our goals. What are our requirements? Anything after post-procedure in a TAVI, there should be no paravalvular leak. So there is no paravalvular leak in the aortogram in the post-procedure. There should be good hemodynamics. So there is no gradient, absolutely a single digit gradient. And there are no conduction defects. There is no requirement of pacemaker. So coming to the next subset, coronary access and transcatheter heart valve. So TAVR has increasingly chosen in the younger patient now also, especially after data from the low risk and intermediate trials. But the demand for coronary angiography and percutaneous intervention during the follow-up is anticipated to rise. A post-TAVI patient can develop an MI, and we have to access the coronary. So what this study is from the JAC, the coronary access and the THV valve. So this is called caveat registry. So what they have studied is they have chosen the different valves, like Sapien 3 is a balloon expandable valve, OTO is a self-expandable valve, Accurate NIA is a self-expandable valve, Evolute Pro is a self-expandable valve. And they have, in the post-procedure, they have studied the feasibility of the coronary access after TAVR. So the green color indicates the exact selective cannulation of the TAVR. The yellow color non-selective cannulation. That means the catheter can be somewhere in the sinuses nearer to the ostium, but not exactly into the ostium. In the red color one, absolutely no access to the coronaries, whatever you do. So you see the short film valves do better in terms of the coronary access, around 90% selective cannulation and 98% some form of cannulation. But if other self-expandable valves, you can see only 50% selective cannulation and 9% we have not able to access the coronaries. So if you choose a balloon expandable valve and if you implant the valve with a little depth into the LV and if you achieve a commercial alignment, then the probability of accessing the coronaries will be high. So for coronary access, if the other anatomical features favors a balloon expandable valve, choose a balloon expandable valve. If other anatomical features demands a self-expandable valve, then choose a self-expandable valve with a large open cell so that your coronary guiding catheter can easily go into the ostium and deploy a little low so that coronary obstruction is less and achieve commercial alignment so that that transcatheter heart valve commercial alignments may not fall on the mouth of the ostium. Coming to the low coronary height and coronary obstruction. Suppose if you are doing a valve-in-valve procedure, already there is a surgical valve and surgical valve leaflets will be there. And if you are placing the transcatheter valve inside it, the initial surgical transcatheter valve leaflets will fall onto the coronary ostium and cause a coronary obstruction, which is a catastrophic. So what we have to do? We can do two things. First, choose a valve with less coronary obstruction. If you have to choose a valve and you have to prevent the coronary obstruction, then use the protection strategies. What are the protection strategies? Then keep a stent at the coronary ostia while deploying the valve. So immediately after deploying the valve, if there is a coronary obstruction, we can pull back that stent and deploy in the left main ostium or the right coronary. And other techniques called leaflet modification techniques are there, like basilica and shortcut or unicorn, not important at this level of discussion. But remember, there are some leaflet modification techniques which will prevent the coronary obstruction if you are doing pre-procedure in a patient with high risk for coronary obstruction. Coming to a case example, this is an 84-year lady with severe dyspnea, severe aortic stenosis, and some form of LVOT gradient is also there. We can see LVOT gradient is also there in this patient. So there are two levels of obstruction. One is at the valvular level. We can see this contour. The other contour is the characteristics of your HOCM. So this patient, the annulus is 19.1. So it is small annulus. And we can see the coronary height is 7.4. That means height of the coronary from the, on the left coronary is 7.4 and right coronary is 11.3. Coronary heights anything less than 10 is called low coronary heights. And here I am introducing one more term called aortic angle. That is angle between the aortic root and the horizontal line of the across the heart. This is called the aortic root angle. If the aortic root angle anything greater than 45, it is called horizontal aorta. So implanting a transcatheter heart valve in a horizontal aorta is the challenging because of the navigating the transcatheter valve system. And the femorals are okay. 6.7, 7.1. I told you anything greater than 6 is good. So what are the challenges in this patient? This is an elderly female patient, small annulus. It is a bicuspid valve type 1A calcified raphe and low coronary heights. It is 7.4 and narrow sinuses. Any sinus less than 30 is called narrow sinuses, and it is a horizontal aorta. The angle is 66, and we have some associated LVOT gradient also. The main point in this discussion is the low coronary height. So what we have done in this patient, so we have chosen a protection strategy called coronary protection with a guide liner and wire inside the left coronary artery while deploying the valve. We have chosen a balloon expandable valve in this patient. Similarly, again, the pigtail pacing. The extra thing here is the coronary guide liner, and a wire in the left coronary. So we are prepared. If after the deployment, if any coronary obstruction, we'll take a strand through this guide liner and we'll deploy. This is called the chimney stenting and coronary protection. But luckily in this patient, after deploying the valve, so we can see there is no coronary obstruction. So we have withdrawn everything. If there is any coronary obstruction, we would have deployed the valve. Coming to the other subset, valve in valve position and transcatheter valve choice. Here there are two subsets. One is TAVI in SAVI, that is transcatheter heart valve in SAVI, and transcatheter heart valve in TAVI. TAVI in TAVI or TAVI in SAVI. So what are the challenges in TAVI in SAVI? Patient pro-6 mismatch. Already a valve is there, surgical valve, and we are further compromising the aortic route with another transcatheter heart valve. So literally it is placing the valve in a small annulus. The problem is patient pro-6 mismatch. And I told you the coronary obstruction, because the initial surgical aortic valve leaflets may impinge on the coronary ostia by the transcatheter heart valve. So per patient pro-6 mismatch, already we know till the discussion we know that it is the self-expandable valve which is better. So for TAV in SAVI, if you want to get a better hemodynamics, choose a self-expandable valve. So this is the difference between the self-expandable valve and a balloon expand valve in terms of the gradient. So the self-expandable valve achieves better hemodynamics in a TAV in SAV than a balloon expandable valve. The other problem, coronary obstruction. So choose a balloon expandable valve if you are able to choose. If you want to choose a self-expandable valve, implant at a lower level, or choose one of the protection statuses I told, like a chimney stanting or basilica procedure. So this is coming to the TAV in TAV. So what happened here? There is already a transcatheter valve, and if you are placing another transcatheter valve inside this leaflets will fall onto the coronary ostia. Basically, the second heart valve will convert into this first heart valve into a tubular graft, and this tubular graft may impinge on the coronaries. So this upper level is called the neoskirt, because we are creating this is the normal skirt, but whenever these leaflets are impinging onto the coronary ostia by the initial valve, so this is called the neoskirt. So this neoskirt height should be at the lower level of the coronary ostia, then there will be no problem. If this neoskirt is extending above the coronary ostia, then we have to choose one of the leaflet modification or choose a different heart valve so that there cannot be a coronary obstruction. So this is a very busy slide, but I will explain in a nutshell. So these are the different heart valves. This is the Sapien is a balloon expandable valve. My valve is a balloon expandable valve, and these are all the latest self-expandable valves like Acrate, Biosensors, Allegra valve, and Score valve, and Portico. So if these are called the short frame valves and these are called the tall frame valves, these are all the intraannular valves and these are all the supraannular tall valves. So if this is depending upon the type of the index procedure valve, we have to choose the second valve. Suppose if patient is having a Sapien valve, then we have to choose a valve such that when we are placing the valve, this neoskirt height should be at the lower level of the coronaries so that there can't be a coronary obstruction. So like that, if you choose different heart valves, suppose initially a short valve or a balloon expandable valve. So if you choose a short valve in this, it is called short in short. Suppose the initial valve is a short valve, and if you are placing a self-expandable valve in it, it is called tall in short valve. And if both are tall valves, it is called tall in tall. And if one is short and one is tall, it is called short in valve. So we can have 4 different combinations depending upon the index valve and the second valve, either short in short valve or tall in short valve or tall in tall valve or short in tall valve. So among this, the better combination is the short in tall valve, because if you tall in tall, there is a lot of metal and increase the risk of coronary obstruction. So the better valve will be the short in tall valve. Already is an evolute valve, and we can position our short valve such that the leaflet will not impinge on the coronary ostia. So for that, we should know each valve anatomy in detail. So we should know what is the level of the position of the leaflets, what is the height of the leaflets when they are opposite to the valve frame by the second valve, and we should know the compatibility. Suppose if you choose in the sapien valve, it is compatible in any of the index valve. So if you choose a balloon expandable valve, you can place in any of the index, whether it is a balloon expandable valve or self-expandable valve. But for the self-expandable valve, there will be a limitation. We can't place a self-expandable valve inside a self-expandable valve. You can place inside a balloon expandable valve, but this red mark, that means inside a self-expandable valve, we can't place another self-expandable valve. So what about the pacemaker? Pacemaker risk. I already told you for self-expandable valve, there is a high risk for pacemaker because of the long valve frame impinging on the conducting system. So this is the membranous septum where the bundle of his traverse from the left, from the right into the left. So there will be interaction of the valve frame at the this membranous septum, and there can be a conduction defects which requiring the pacemakers. So there are different parameters by which we can assess a patient requirement of the pacemakers. Suppose the patient is having pre-existing left bundle branch block or right bundle branch block or first degree AV block, there will be an increased risk of pacemaker. A patient requiring more pre and post dilatation, injuring the connecting system will require pacemaker. Coming to our topic of interest, if you choose a Medtronic or Corvair self-expandable valve, there will be a high odds ratio of the requirement of the pacemaker rather than a balloon expandable valve. I'll tell you an example. This is a 72 years diabetic and hypertension with severe aortic stenosis. TAVI was planned, and this is a pre-procedure ECG of the patient. We can see the QRS is narrow, but if you see there is a PR interval is prolonged. So already the patient has a first degree heart block, which places him at higher risk for the pacemaker. So these are the CT scan analysis. We can see there is a severe calcium at the non-coronary and right coronary cusp. And we measure the membranous septum length. This is only 5.1 and 3.4. Anything less than 4 or around 3 is a high risk for the pacemaker. And because of the high risk for pacemaker, this patient, we have choose a balloon expandable valve with a high implantation around 90-10% with less oversizing. And post-op day 1 he is okay, but day 3 he developed an episode of syncope, and this is the ECG, and day 3 we can see there is a high degree AV block. So in spite of choosing a balloon expandable valve and implanting at a higher depth, still we got the high grade AV block in this patient. So you end up in having a pacemaker. Coming to our last topic, aortic regurgitation. So the problem with aortic regurgitation and TAVI is, so like in aortic stenosis, there is no landing zone or calcium in the aortic root to hold the valve. So lot of valve migration will be there. So generally, if you choose the initial generation valves, we have to oversize more, around 25 to 30% we have to oversize. Still we get the valve migration and the paravalvular leak. So this is a newer generation valve called GINA valve, which holds the aortic root not only at the annulus but also at the level of the leaflets. It captures the leaflets. So this is an ideal valve for the aortic regurgitation. It is still under development. Hopefully next 1 year or 2 it may come to India. Coming to the alternate axis, sometimes we can't do the TAVI to femoral route. We have to choose a transaortic, transcarotid, or transaxillary. So for that, we need a balloon expandable valve may be a better because of its short valve frame, it can easily navigate to the tortuosities. Of course, the latest self-expandable valves also they had made the catheters in such a way such that they can navigate to the alternate axis like a carotid or axillary. So coming to a case example, we can see this patient, all the aorta, abdominal aorta, and starting from the iliac, it's heavily calcium and narrow, less than 5 inch at some point the caliber. So we are not able to do the transfemoral TAVI in this patient. So we have imagined the carotids. So carotids are perfectly okay in this patient. So we have done a transcarotid TAVI in this patient. We can see our surgeon has opened the neck and exposed the carotid artery. And through the exposed carotid artery, we have placed the sheath, the large sheath. It is called python sheath from the middle. And we have finished the procedure from the above. So in this patient, in all the case examples, we have seen coming from the femoral, we have deployed the valve. In this case example, we are seeing coming from the above, we have deployed the valve. So this is the transcarotid TAVI. So coming to the conclusions, so whenever you have to choose a valve or a TAVI, depending upon the anatomy, so if the patient is having a bicuspid valve or a LVOT calcium, if you choose a self-expandable valve, there is a high risk of paravalvular leak. If you choose a balloon expandable valve, there is a risk of annular rupture. So choose, weigh between the annular rupture and the paravalvular leak and choose a valve, whether to choose a balloon expandable valve or self-expandable valve. The patient is having small annulus. To get a better hemodynamics, choose a self-expandable valve than a balloon expandable valve. For future coronary access, if you are able to choose a balloon expandable valve, choose a balloon expandable valve. If you want to choose a self-expandable valve, choose a self-expandable valve with large open cells and attain a coronary or commissural alignment during the deployment and deploy a little low so that coronaries can be accessed easily. Suppose if the patient is having low coronary heights and risk of coronary obstruction, we have to choose a protection strategies like a chimney stenting or basilica procedures. For valve in valve, for TAV in SAV, for better hemodynamics, we have to choose the self-expandable valve. For coronary safety, we have to weigh it against the balloon expandable valve. For TAV in TAV, balloon expandable valve is maybe better than the self-expandable valve, but it all depends upon the index TAVI valve. So short in tall is a better combination. For patients with higher pacemaker risk, balloon expandable valve may be better than a self-expandable valve. For patients with pure aortic regurgitation, right now we are oversizing the available balloon expandable or self-expandable valves, but if Gina valve comes, it may take its place for the pure aortic regurgitation. For alternate axis and horizontal aorta for better navigation, balloon expandable valve may be better, but with the latest generation self-expandable valve like an evolute FX, it can be possible to alternate to access or even alternate routes also. Thank you for your patient listening, and I'm happy to answer any questions.